Welcome back. We're so glad to be able to continue our program this morning. I'm going to ask the people in the room to grab their seats so that we can actually begin. Thank you, all of you who are online waiting for us to get started. We noticed that we're a little bit behind in the agenda today, but I think that things will work out fine. We're going to now enter the segment of the day that is really from our clinical care subcommittee. And we have various presentations as part of that. And we're going to start with setting the tone by understanding the perspective of a person living with dementia. And that person is Dr. Sarah Langer, who is going to be our presenter. She's actually going to do this as a video, but I wanted to give you a little background on her. Dr. Sarah Langer is a 66-year-old retired neurologist, and she's living with mild cognitive impairment from dementia with Lewy bodies. She belongs to a family with at least 3 generations of the disease. She and her older sister, who is a psychiatrist, began noticing deficits in attention around the age of 50, 51. Her younger sister developed symptoms in her mid-40s and died at 62. Sarah and her husband have 2 sons aged 31 and 37. So we're going to play this video from Sarah and then launch into a few minutes of discussion. Thank you.
Hello, and thank you for asking me to speak with you today. I'm a 66-year-old former neurologist living with, as yet, mild dementia with Lewy bodies. My assignment today is to talk about my experience with care after diagnosis. Where does the magic happen that propels a person from a diagnosis of a progressive, debilitating illness to a successful life? My answer is in community. With apologies to Charles Dickens, I'm going to illustrate my point by telling the tale of 2 sisters. My sister, who is 2 years older, and I both began noticing subtle cognitive symptoms intermittently around age 50, 51. Coincidentally, both of us left our jobs that we loved because of progressive cognitive difficulties at age 56. My sister was a child psychiatrist and the medical director of a multidisciplinary clinic in New York City. I worked as a clinical neurologist in Minneapolis. I was diagnosed with mild cognitive impairment felt to represent prodromal dementia with Lewy bodies at age 59. My sister was diagnosed in her early 60s only after an occupational therapist performed a kitchen eval and called her cognitive disorders specialist to report that my sister's obvious deficits became apparent in that eval. And these deficits had not been so pronounced on neuropsychological testing. We both have loving husbands, yet our functional capabilities have become increasingly divergent since diagnosis. After diagnosis, I threw myself into learning everything I could about dementia with Lewy bodies, from basic biology to lifestyle modifications and treatment. I explored support groups both online and in person. I was open with almost everyone about my limitations and found useful information and connection in most unexpected places. In contrast, although my sister was eager to learn whatever I could share with her about DLB, she was loath to discuss her difficulties in diagnosis, except with her husband, her doctors, and me. Although my sister was an avid reader and talker, she did little independent reading on dementia and didn't contact organizations focused on dementia. Both my neurologist and my sister's cognitive disorders neurologist at a premier referral and research center initiated low-dose donepezil. We both experienced significant improvement on donepezil. I followed up as frequently as I needed with my doctor in clinic or via patient portal, whereas my sister saw her neurologist only once a year. I felt more informed and proactive in my healthcare because I read, sought out dementia advocacy organizations, and attended national and international meetings. My husband supported my pursuits. I requested and received physical and occupational therapy and psychiatric care. I discussed what I had learned in various settings with my doctors, and together we optimized my medications. As a result, I feel I am living a full, rewarding life, and despite limitations in driving, complex finances, concentration, and general energy. In contrast, my sister relied almost exclusively on recommendations of her doctor, who did not suggest any therapeutic interventions other than donepezil for cognition and melatonin for REM behavior disorder. I repeatedly urged her over a couple of years to add memantine, then venlafaxine to enhance her cognitive function and reduce anxiety. However, she was reluctant to bring up these suggestions to her neurologist. Finally, she did, and she was started on them, but the neurologist hasn't been proactive in optimizing her medications, and she remains on subtherapeutic doses of all medications except donepezil. I will remind you that her doctor is a cognitive disorder specialist involved in observational and clinical trials in dementia with Lewy bodies. My sister is now unable to use her smartphone or computer except for phone calls and emails. She has considerable difficulty with word finding and tracking conversation, and slowly writes down all important information, then can't find what she's written. She misses medication doses. Although she was once a brilliant cook, she is now only able to prepare a couple of simple things for a meal. My sister's husband takes her to appointments, but generally doesn't ask questions. His only question at the time of her last appointment, when she was clearly getting worse, was whether she could drive. He was told no. He is well aware of my sister's difficulty, yet he makes no effort to familiarize herself with her medications or help administer them. He does not request ancillary support services or promote exercise, a healthy diet, or social engagement except for rare parties at their home. Her doctors assume that she has a care partner because her husband is present for appointments, but that is the extent of his involvement in her medical care. Despite having plenty of favorable social interactions with doctors in the family and in his social sphere, my sister's husband doesn't buy into the idea of medical care systems promoting health. Rather, he seeks medical care for himself or his loved ones only when they are in distress, such as having trouble breathing or intractable pain. It took my sister over 3 years to begin an intravenous osteoporosis medication because her husband wasn't willing to help her decide which one to pursue in their insurance formulary. In the absence of a medical community, including detail-oriented physicians and allied health services, and in the absence of broader community supports, my sister is going down the tube. She is now incapable of harnessing the support she needs on her own. For people with cognitive impairment, their future health depends less on their actual pathology than on their support systems. Paths diverge sharply for people post-diagnosis based on access to the following. Number one, good spousal or family support. This may include families of choice rather than biological families. And physicians should suggest active care partners when family members do not seem engaged. Number two, access to support groups. I'm reminded of a Mayo Clinic doctor with a blood dyscrasia who said she got more valuable information from her support group than from her Mayo Clinic physician. Number three, access to community resources such as healthy groceries, nutrition, and education and services. Think about the programs in which doctors' prescriptions for fruits and vegetables financially support low-income individuals. Access to exercise, art, educational, and social programming. Access to transportation, housing, and household support, such as finances, cleaning, and shopping. Help with medication access and adherence. Help with communication devices, such as phones and computers, to stay connected to medical appointments, for self-education, and to socialize. The relationship between cognitive health and community engagement and services and services is becoming ever more apparent. If we are to contain medical and public expenditures and improve health outcomes, we will need to develop broader integration of conventional physician visits with allied health personnel and community services. It's my conviction that every person upon presenting with cognitive concerns should be evaluated by an occupational therapist or speech pathologist, psychologist, and social worker to help focus the diagnostic evaluation and to determine what community services, including support groups, might be of most benefit. This approach of assessing patients and their needs outside the doctor's exam room should be revisited on a yearly basis. I believe this will be the key to improving outcomes and reducing caregiver burden going forward. Doctors need to buy into the concept of care teams. I think they will find this model acceptable if they are not responsible for organizing or monitoring the care team. Thanks very much for listening.
My goodness. Dr. Langer, I want to welcome you. I'm Helen Metzger, and your family's story actually parallels mine. So I have a very deep interest in this entire discussion. But I think it took a lot to be able to come forth and illustrate the importance of being proactive in one's care, educating yourself and your care partners. Get the families involved with any of the diseases so that they're well educated and understand. To be able to bring forth your own family's personal history, I think takes a lot of courage, and hopefully your sister understands. But the benefit of multidisciplinary approach to care, services, and supports is essential. Now, for the people living with cognitive impairment, their future health really does depend less, on actual pathology than the support systems. I love that statement. It really does. It speaks to us not accepting that diagnose and adios, saying go home and get your affairs in order. It is time for those to acknowledge that it is just a new chapter in our lives and we need to embrace it. So although unfortunately we don't have a lot of time for any further discussion, but I would like to ask Dr. Langer if she has any additional comments and possibly even a statement to her colleagues in the field so that they may embrace and encourage their health systems to get on board with the whole concept of bringing in allied health professionals to be able to support these families and the person living with.
Well, thank you, Helen. I don't really have any additional comments except to say that rather than a top-down approach, I would like to see more of a collaborative approach.
Very good. I think that's essential so that the voice of the individual, the voice of the family is in unison in convening with the physician and the health professionals. I think that's a statement that all the NAPA Advisory Council members would agree with. So thank you again. And I think we'll move on to our next segment.
Thank you very much. This has been very informative and helpful for setting the stage for the day. And so thank you, Dr. Langer, and thank you for Helen for managing the discussion. We're going to move to our next presenter now. Our presentation is going to be on the Dementia Ideal Care Map, and this is going to be led by Dr. Wen Dombrowski. She is a physician executive who is double board certified in clinical informatics and geriatrics. Yay, another geriatrician. But she's a healthcare innovator, and she's a principal at the company called Catalyze. She has provided medical care to patients across the continuum, from house calls, senior centers, assisted living, nursing homes, outpatient clinics, inpatient hospitals, emergency department. Before she became a physician, she worked as a caregiver for people with dementia in assisted living, adult daycare, and community settings. So she brings a wealth of information and perspective to her role. And she's been previously the Chief Medical Information Officer overseeing IT, telehealth, and digital patient engagement. She's an adjunct professor at USC, teaching something interesting, gerontology, gerontechnology, and technological innovations in aging. I'm sure you're going to enjoy this presentation by Dr. Wen Dombrowski. Wen?
Is it on now? Can you guys hear me okay? All right. No problem. Thank you, Dr. Mims, and for the Advisory Council. My name is Wen Dombrowski, and as we get the slides pulled up, I just want to point out for the people in the room, there are copies, paper copies of the Ideal Care Map on your tables as well as on the wall. And for those who are at home, this is actually available for download for free at linktree/care map. So feel free to follow along as I go through the different slides. Is that better? Okay. Right. So since Dr. Mims already introduced me, I'm going to skip over this slide, but I'm glad she shared my perspective, my background, because it informs the perspective from where this project came from. So first, I'd like to provide some background about how the Ideal Care Map became into fruition. And my colleagues and I, we noticed that there are a lot of different organizations, academic organizations, government organizations, as well as industry groups that have put out a variety of best practices. But these best practices tend to be focused on only one part of the patient journey, or only focused on like one relevant group, such as what do doctors do or what do patients do. And these tend to reside in silos of different repositories of information. So the goal of creating the Ideal Care Map is really to combine an ecosystem of care and to really look at the best practices, not just from the physician's point of view or patient's point of view, but to really look at all the different stakeholders and relevant groups' point of view. In addition, there's also proposals of new care pathways and processes to enhance the current state. The goal really was to make this a resource that's publicly available so that it can help policymakers, health system leaders, community organizations, as well as people living with dementia and their families. So I'm just going to give a quick overview of the methods. So basically what happened was I first searched PubMed for journal articles and for clinical practice guidelines, as well as looked on Google and different organizations' websites for white papers and for toolkits, and then extracted from over 100 different resources globally the different best practices, and then visually summarize these best practices on a diagram. It was initially very messy and lots of different moving pieces, obviously. But what was very interesting is in the visual analysis, there were some things that became apparent that were not noticeable when it was not in diagram format, which I will be sharing in further slides. So after summarizing what's already been published, and I analyzed the visual diagram, and it became apparent what are some of the gaps, opportunities, and some potential new care processes and pathways that could be proposed. And in addition to what's already published in the best practices literature, I also added an array of different technologies based on my personal and professional experience with technologies. So after creating that draft, I involved dozens of different subject matter experts globally, including one-on-one interviews with both group feedback as well as one-on-one interviews. And I'd like to acknowledge Dr. Mims, her involvement in providing feedback on this project, as well as Ian Creamer in the back. He also provided valuable feedback as well. And so based on the feedback, we iterated the diagram, and this is what you see today. The diagram is by no means perfect. It's really a first draft, I would consider, but what I'd like to just share at a high level first is that this diagram captures over 200 best practices in one comprehensive view. And if you look specifically at the gray boxes, there are almost 100 different technology solutions and technology categories that are listed next to the best practices to enhance and support those best practices. And I'd like to also just kind of walk you through and orient you to the at-a-glance view before we dive down deeper. So first of all, it's color-coded because the So like for example, I know it's hard to see on this big screen, but if you look at the one in front of you, the purple, actually, does this have a, let me see if this has a, yeah, I don't think this has a laser, but basically the purple sections on the upper right refer to things that involve caregivers, best practices and best practices and tasks that involve caregivers. And then the pink sections towards the bottom, that involves people who are either at risk for dementia or people who have dementia but have not yet been diagnosed. And the blue sections on the bottom represents people's with dementia's interactions with the healthcare system, with the medical system. And the yellow sections in the middle refer to community-based organizations and social services. And then the last two, but not least, is throughout the left column, that represents the orange section is infrastructure and other stakeholders. And gray, I mentioned already, is technologies. So I know it's a lot of information to cram onto a page, but the goal, like I said, is to really have a one-stop shop at a glance view to pull together many different best practices. Oh, and one more thing I wanted to mention is that arrows going to the right generally flow temporally, so sequentially. So the things on the left, which are the foundational infrastructure enablers such as policy, technology, research, translation, education and training, that comes as a precursor to things like awareness, risk reduction, diagnostic workup, and ongoing medical care. And when you look at the little circle type arrows, that is to represent there are tasks that are happening reoccurring or they happen intermittently, because in traditional care pathways, it tends to depict things that are linear from one side to the other. But what we realize when we visualize it is actually many steps kind of, you go back and forth and you sometimes get better, you get worse, you get better. And this here is just a very high level view of the diagram to show that in many traditional care pathways, it's focused on really the red boxes, like initial detection and diagnostic workup. But the comprehensive view is to really coordinate and integrate all the different parts of the ecosystem. So since this council has already focused a lot on risk reduction and detection, today I'm really going to focus on the parts that I've circled. I'm just going to do a quick deep dive into each of them. And like I said, feel free to follow along on your paper copy or to download the full diagram, and the article with the commentary is available for free online. So first, I'm just going to talk briefly about data infrastructure. I'm not going to read to you all these points, but I wanted to highlight the importance and need for a national data strategy and national data infrastructure. And this is especially important in the realm of dementia care because, as you guys already know, there's not just the health systems with medical data, but there's also social service providers, community organizations with information about social determinants of health and social services that were actually delivered. And when I say data infrastructure, I mean both hardware, such as like physical servers and where you physically, the physical hardware, as well as software applications, as well as the workforce needed for managing the data, whether it's data collection, data cleaning, data integration, data analytics. And there's really an opportunity, I would say, based on what we're finding from this care map, as well as what I'm hearing in the room today, there's really an opportunity to recommend a tighter integration and tighter harmonization of the data sharing between the medical health system, social services system, and the reimbursement payer system. So next, I'm going to go to the next panel. And for those of you who are following online, I'm still in the left column in the second chunk of the left column. So basically, this box is really highlighting examples of digital technology solutions. And these are not just for the initial detection and diagnosis, but can also be used for ongoing monitoring as well as ongoing support. So, for example, clinical decision support tools and patient decision support tools to help understand what are services and supports and treatments that are appropriate for the current stage of care. And even this morning, I was just chatting with Ian Creamer, and he was saying, oftentimes people come up to us because they know we work in dementia, and they say, what should I do for my dad, or what should I do for my family member? They've got this and this and this and this problem. And really, I'm hoping that the ideal care map would be the foundation of creating a more personalized, like a personalized recommendation tool. So additional types of technologies that are important and valuable for people with dementia includes digital assessments, both not just for the diagnostic journey, but also to monitor the progression of disease. So when I say digital assessments, I know people know about things like questionnaires and neuropsychiatric testing, but there's also on the horizon things like analyzing the voice, analyzing the eyes, analyzing people's movements and their mood. And these can also provide additional information about the disease progression, as well as what types of different services and supports might be helpful. So I'm just going to, the details are there, so I'm just going to move on to the next slide. So for those of you who are following the whole map, this is towards the top of the map, right under the title. And what's really interesting about this section of stimulating activities is that initially I was thinking about, behavioral, like people who have behavioral symptoms. It's often recommended that they do things like music therapy or, involved in movement. And then when I was also looking at the best practices for risk reduction in early life, as well as risk reduction for people who are diagnosed with MCI, I realized that many of these activities, such as, exercise and being socialized and being involved in creative expression, these are the same activities throughout the lifespan. And so I do think there is an opportunity to recommend promoting these types of activities from early lifetime throughout midlife, and then also after diagnosis. And next on the slide, I'm not going to go through each of these areas, but this is the yellow section that's kind of towards the upper right of the diagram. And what I wanted to point out is that I was trying to think about community-based organizations, social services, which I know the people in this room, this is things you guys already know about, but just to kind of clarify for people who might be watching online, what I was thinking about the role of community services and social services, and I broadly categorize them into general groups. One is more like information sharing or talking and things that don't necessarily have to be done in person, but could also be delivered online. And then the second yellow box is things that require hands-on care, such as, helping people get dressed, helping people eat, get bathed. And I'm not going to dwell on this because I know Aaron and some other people will be speaking more about these types of topics. So I'd like to just highlight some examples of technologies that can support the community-based organizations and social service delivery. So for example, I've heard that there's many states and locations that the AAA does not have an online directory. So caregivers are forced to call during very limited office hour times to ask, I need help with this or I need help with that. And so a potential opportunity and something to recommend would be to create online directories that are publicly accessible from people from all over the country, because a lot of times caregivers actually don't live locally. They may live in another state. I'd also want to just, I already mentioned that there's a lot of opportunities to use technology for online supports like counseling, peer support groups, telehealth, telemedicine. And earlier I mentioned with data infrastructure, there's a need for shared documentation, shared data sharing, information sharing, and coordination across the healthcare system and community organizations. And then I want to just also mention the role of telehealth and telemedicine. Obviously, this box is focused more on community organizations, but I think we should think about telehealth broadly with the entire care team, like Dr. Langer mentioned earlier, where you're thinking about how does a patient or their family members and friends interact with the whole care team, whether these are medical doctors and medical providers, or if these are counselors or other members of their care team. So next slide. I really love Dr. Langer's presentation because so many of the things she mentioned are actually captured in the slides I'm presenting today. And so this slide specifically is really to call out the need to identify who are the care partners for individuals, as well as the need to support care partners, because oftentimes medical professionals will assume that someone's spouse or someone's kid is automatically going to take care of everything that some person living with dementia needs. And that's actually not realistic, since a lot of times, just like Dr. Langer mentioned, some spouses don't know what to do, or they're not interested, or they're not willing. And so this box really specifically calls out the need to assess who is willing to be involved, what are they capable of doing, what do they need help with, and then to refer them to the appropriate information and services. So I'll leave, you guys can look at this in detail, but that was a summary of this slide. And then this next section continues on the different recommendations related to caregivers. This is the upper right section on the whole map. On the first column, these are really interaction strategies. So it's how can, actually, this one is not just about like family and friend caregivers, but it's also like paid care workers, care managers, home health aides, nursing home workers, and things like that. And on the first column is interaction strategies. So it's really about how are ways that care workers and care partners can communicate and cue the person living with dementia, and also ask what are their personal preferences, what are their likes and dislikes, and really involve the person living with dementia in as much as they are able and willing to do. And then the next three columns are care tasks that are organized by frequency. So in the second column, these are care tasks that are done occasionally, such as legal planning, financial planning, advanced directives. And then in the third column, this, as people need more help, as disease progresses and people need more help, these are the caregiving tasks that are typically done weekly, such as organizing medications or helping get groceries. And then on a monthly basis, it could be something like paying the bills or cutting the grass. And then in the last column, this addresses the needs of people with the most severe disease, where they need help with ADLs and the day-to-day, just their day-to-day, using hygiene and food and things like that. So I'd like to also share, as part of the visual analysis of the draft diagram, what I did and what I asked our subject matter experts to comment on was looking at the diagram and the different opportunities and gaps that are presented in the diagram. Where are there areas that are potentially amenable to quality measures? Like at what step or what best practice would be helpful to have a measure to just have improved accountability of services delivered and to be able to do quality improvement. And so without reading the full list, I just want to highlight some of the ideas that that came up. Include something like having a quality measure about whether a primary care physician has assessed someone's cognition annually, if they're over age 65 or have certain risk factors. Also, a quality measure about disclosing the diagnosis of dementia, because I've heard that there are some patients who clearly have something wrong cognitively, but their physician has not actually explained this to the patient or their family members. And then other potential quality measures include assessing the family's willingness to participate as caregivers and care partners, and then also referring to community-based organizations for additional information and support. And then also documenting people living with dementia's preferences, likes, dislikes, and goals. So these are some of the measures. And this table actually is in the article that you can download for free at linktree/caremap. There's like a table of these recommended measures. So I just wanted to share some of my observations from the visual analysis. And honestly, these types of observations would not have been apparent necessarily by just reading a list of recommendations. And so the feedback we got from the different subject matter experts who've looked at it says it's really helpful to have one compact view, to see everything at a glance, the whole ecosystem, and how the different parts of the ecosystem interact, whether it's, how the researchers need to be thinking about what care partners do, what the medical system does, and then and vice versa. And then also this specifically is a person-centered life course view, which Ian Creamer and some of the other subject matter experts are very insightful in helping think of, like, really rethink, instead of a medical paradigm and medical pathways, really rethink the patient's life journey from birth and young adult risk reduction into later life course. And what we also recognize that the psychosocial best practices, I think historically or traditionally, I tend to see things that are like you get diagnosed, you get screened and diagnosed, and then you get medical care and you get medications, and then you're referred to social services. Whereas in this diagram, we've specifically, explicitly put the community-based organizations, social services, and activities up front earlier in life, because these groups can be interacting with people and families even prior to diagnosis to provide pre-diagnostic support and to provide risk reduction. And then later on, they can provide post-diagnosis support. I've already mentioned the journey is non-linear. There's cyclical, continuous, and fluctuating journeys. And the other thing that became apparent when we looked at the diagram is that, more recently people think about, well, okay, after you're diagnosed with Alzheimer's, you might live for 5 to 10 years. But then we realized that if we are diagnosing people earlier on because of more aggressive awareness and detection activities, and people are receiving some of the newer treatments, then people's life course could actually be living to 20 years out. And so there really needs to be a different type of anticipatory guidance and different ways that clinicians are explaining the diagnosis to patients, that this might be something like a chronic disease that, for example, diabetes and HIV, it used to be considered, a death sentence or something like that. But now we can really think of it as a chronic disease that you can optimize and live your fullest life. Additionally, the other observations from the visual analysis is that many, many, many of the best practices can be performed by non-physicians. And I think it's important to recognize this because there is an epidemic of physician burnout and physician shortages. And so this map lets us really to reconceptualize who on the care team within health systems and outside of health systems can, support patients, whether it's through information, direct services, care navigation, checking up on how are you doing? Do you need more help? Are your symptoms getting better or worse? And then last but not least, I mentioned the gray boxes are technologies that are paired with each step of the best practices. And it's really to just show that there are ways to enhance the human efforts. Like there are obviously already human efforts and program and administrative efforts for these best practices right now, but technologies can further amplify those efforts. Now I'm on my last slide. And then I'll be taking questions after this. So this is really the applications that I wanted to talk about, and the potential next steps to it is I really welcome feedback and collaborators. So if any of you guys have, different ideas for it, or if you're like, oh, we're missing this and that, I totally welcome any feedback. And my vision actually initially before we created, my vision was actually to create this as an online interactive tool. Actually our version 1 was an online website that you can click on. And when you clicked on each little box, it actually popped up the text of all the different clinical guidelines and all the different practice guidelines. And actually I had a lot of the NAPA recommendations in there as well. So you probably have, recognized many of the best practices. And the other thing that I think that can be done with this care map is to create customized versions of it, adapting it to specific regions, specific states, or specific organizations, and also to either specific subtypes of dementia. So this is really just a starting point when I'm presenting, and it can be used as additional tools. I'd also want to point out that this style of diagram comes from a discipline called capabilities architecture, that comes from more of the business and technology world, which I'm also in. And so it's really a map of, capabilities that the whole ecosystem needs to provide. And there are tools and ways where you can actually use it to do a gap analysis of, if we're looking at this particular territory or this particular organization, what are gaps in their plans, and then be able to do capability maturity planning off of it. The other applications for this care map is that I'm hoping that clinicians and care workers and researchers will be able to look at the entirety of the care map to really understand what are the other roles involved beyond their own silos of experience and their own silos of work, because I think it does improve, for example, for researchers, it does improve their understanding of research if they understand what are some of the downstream impacts. And then for clinicians, can help them understand the community organizations and caregiver roles. And then last but definitely not least is for people with dementia and their care partners and for lay people to be able to use this map and especially the sections on the right to as almost as a checklist to inform themselves of what are things they can be doing to help their loved ones. And my hope is actually if there's any organizations that would like to create like a more customized recommendation engine based off of it so that people who say I'm at this stage with this need, and then it would highlight more specific recommendations for them. So to recap, I just wanted to mention some of my key recommendations that come from the ideal care map concept. So first I mentioned to use it as an education and planning tool for both professionals, organizations, and families. And then second, I think there's a need for tighter integration and data infrastructure between healthcare, medical data, social services data, and the reimbursement systems. And then third, I would like to recommend that you can increase the capacity for caring for people living with dementia and their care partners by having virtual brain health clinics and telehealth care models that basically involve care teams, both physicians and clinical care team members, as well as community care team members remotely through telehealth, telemedicine. And then another recommendation is to promote the stimulating activities throughout the life course, starting from an early age and throughout midlife, because it does reduce risk, before and then also can help with symptoms afterwards. And another recommendation is to make the local and state resources available online in online directories that caregivers can publicly access. And then another recommendation is to create decision support tools that help not just clinicians, but also community organizations and families to guide them through the different steps of essentially care navigation. And then last but not least, to have quality measures that hold organizations accountable for the care they're giving and really encourage the continuous improvement of their care delivery. So thank you very much for inviting me here. I'm happy to take any questions or comments.
So this is Ken, and I'm going to quickly, I'd like to extend our sincere thanks to Dr. Wen Dombrowski for her insightful presentation on the Dementia Ideal Care Map. We got roughly about 10 minutes. I'm going to facilitate the Q&A session. Some of the key takeaways that have stood out for me, probably because I got a bit of a IT background, the role of tech solutions such as telehealth and remote monitoring to enable continuous real-time care that can support early interventions, detections, and even significantly reduce hospital visits. And emphasis on what you just described, data infrastructure or data-driven quality measures and insights to help us better understand disease progression and treatment efficacy. We got to match them up. So these points highlight how the Dementia Ideal Care Map can help us navigate through the dementia care landscape to better serve patients and families. We have, I think, roughly about 10 minutes. As we move into our Q&A session, I'll open it up with a question. So Dr. Dombrowski, you highlighted how the Dementia Ideal Care Map personalizes care for each individual. How do we ensure that the technology does not become a barrier for those who may struggle to use it? Examples would be those who I serve, individuals having language barriers and health literacy issues.
Great, thank you for that question. I love that question. So I'm a big champion of user experience design and co-creation and co-design. So I think it's important to create tools with the intended users, and that it's the intended users' input and suggestions and ideas that are being created, so that it's not just, top down from the ivory tower, from like elite academic and government ivory tower telling people on the ground what to be doing and using, but to actually involve those who are using it for what they think would be helpful to them. And obviously doing rigorous testing and getting feedback before something is launched, instead of waiting till after something is launched and finding out like, oh, this app is really hard to use, or I don't understand how to open this website and where to click. And these are all things that can be mitigated with really intentional user experience design and co-design.
Makes sense. I think Helen, you had your hand up.
Thanks. Thanks, Ken. Dr. Dombrowski, I really applaud what I saw here today. It's incredibly comprehensive. I do have a question though. Given, that we know the formulation of, neurodegeneration begins decades in advance of actual clinical symptoms. That's, that we well know, incredibly well documented. And I see even in, let's say, language barriers, where do they look to? Many families look to their children to inform them in the community, to keep them connected, whether they have, if they don't have a technical, background or not interested in technology, their children who bring them along. So you mentioned educators. Well, at what level? I'm looking at, children, very, very young children in their health classes or their science classes, being able to have a simplistic or age appropriate, grade appropriate educational series that would bring it to them that they can then share with their families. Because we need to be educating from the minute they're in school all the way forward in things that are appropriate. How do you think that could be integrated in?
Yeah, I love that idea of involving young adults to help educate their parents and their grandparents. And actually, what you suggested, the concepts of it is in the most left side, left column of the care map under the infrastructure for policy and awareness funding. And then also in the second column where it talks about public education, public awareness, there's an entire section that even comes before initial screening to just really like general awareness of both risks and risk reduction, but also I would say broad awareness of brain health, because we've seen that many of the things that reduce the risk of dementia are a lot of the same recommendations for cardiovascular risk health and general health, good exercise, good nutrition, things like that. And so I really love your suggestion about involving children and teaching children to have healthy lifestyle, healthy brain health early on, and to really engage them and challenge them to have these conversations with the older relatives in their households.
Thank you.
We have, I think, about 5 minutes. Do we have any questions? If
Ken,
not,
this
I
is
can-
Helen in the room.
Yes, please go ahead.
I ask a question. When this is comprehensive and it's amazing, but it's also overwhelming. So where do you suggest people start, or we as the NAP Advisory Council start? Where are the best opportunities to focus this work?
Yeah, great. Thank you for that comment. So I agree, it is overwhelming. It was overwhelming to put it together and overwhelming to review it. And that's why on my slide about applications and potential next steps, what I would love to see is two general categories. One is if there's an online version, people can click on, I am a researcher, or I am a caregiver at this stage in life, and be able to, where it will filter out the things they might not need to know right away and help them zoom in on specific sections. And actually the prototype, like the version 1 of that, actually had this type of functionality where there were different layers and the parts that were not so relevant could be turned on and off. So that's like an online interactive filter version. The second idea is that there's some organizations that are interested in doing like a revised, updated version of this for their type of organization. And so if there's an interest, it could be applied. Like this map was actually involving global best practices and looking at some global health systems and global subject matter experts. And so there could be ways to really customize it to things like Medicare, ACL, HHS, because that's why you don't see the word HHS and Medicare specifically called out in the map right now. So thank you. And if anyone has other suggestions, I'm totally open to it as well.
I really appreciate the map. And I think that the most important part to me is that you really call out that it's not just what happens in the physician office, that life with dementia is multifactorial in the community and that many others can be involved within the team and the person's life after that. And I think that, and I don't know if this is what you were going to talk about, Sherry, but the community health integration services are new codes from CMS that allows the involvement of community health workers to help that coordination with home and community-based services. And there are several other codes, but that in particular allows us to take things out of the clinical care, those 5 minutes or 10 minutes we have with the physician to say, oh, okay, I don't need to write a prescription. I don't need to order a lab test, but I do need to make this referral to the community. And I do need to know what's going on with you so that I can help coordinate that care. I'm going to turn it over to Sherry.
Yeah, and it is not what I was going to mention, but thank you for mentioning that because it does boil down to the operational necessity of how do you pay for things. Thank you for the presentation. It's very expansive, not necessarily overwhelming, but I think gives us a little bit of process mapping here. The challenge for us collectively is if and when this is implemented in the way that we see it being implemented in the best interest of the people who we serve, what will the outcomes look like? So what are the meaningful outcomes? Because, you mentioned quality. It is possible to, there may be some quality measures that are very process focused, and yet we want to go beyond to be able to knit together the care continuum and know whether or not outcomes are actually better. So what would be the outcomes that we would want to target and track? Thanks.
Yeah, thank you for that question, Dr. Ling. So because of time, there were some details I didn't mention in my talk. So in the project approach, the ultimate goal was how do we think about ideal care as the future, how do we think about ideal care of dementia, not necessarily what's feasible right now, but what could be feasible in the next 3 to 5 years with the goal of things that will ultimately improve the quality of life of people living with dementia and their families and care partners. And so that was the overarching framework and goal of how we looked at the best practices and how we put the recommendations together. And as such, one of my last slides, there is a chart, and it's actually also in the publication. There is a chart that compiles a list of different patient-reported outcome measures that are specific to quality of life and specifically to people with dementia's quality of life. So they are not generic patient-reported outcome measures, but dementia outcome measures. So I definitely want to thank you for pointing that out. And I also wanted to comment on what Dr. Mims said about how this is not just involving physicians, but there's an opportunity to involve, wider care teams and other organizations. And when I mention about, taking this map and wanting physicians to learn about it, what I mean by that is not necessarily to have them do all the different pieces on the map, but just have them be at least aware. Like FYI, there are community organizations out there. You don't have to be the one who has to spend all your time trying to explain what's next. You can refer to these other types of organizations or these types of technology tools that will spend the time with patients and families to explain, what do I do now? How do I take care of my will or my finances and things like that? And then also, earlier there was a comment about process mapping. So my background does include process mapping and workflow mapping. And so going back to what Helen had asked earlier about, what are actionable ways as next steps, I mentioned earlier, there's a way to create these. I've done it actually many times with large health systems and large groups where on topics that are not dementia, for example, where you have a big diagram with all these boxes, and there are ways to heat map what are areas we're currently strong on, what are areas we're currently not strong on, and then the gaps are where you can target specific programs, specific recommendations. So there's like a process for doing that.
Thank you, Ken, and thank you, Wen. I appreciate the presentation.
Thank you.
We're going to move now to one of our other presenters, and this is a dementia care provider presentation specifically Hospice of the Valley. We have online with us Dr. Gillian Hamilton. And Dr. Hamilton is currently the medical director of Hospice of the Valley Supportive Care Dementia Program. It is a program that's been selected as a new guide program for persons living with mild, moderate, and advanced dementia. She's faculty of University of Arizona College of Medicine and professor of practice at ASU, a teaching mindfulness in medicine position. Dr. Hamilton received recognition for being listed for over 10 years in Phoenix magazine as one of the best doctors in Phoenix. They love her. And as a recipient of numerous awards, including the National Library of Congress's Local Legends Award and the Arizona Geriatric Society Lifetime Achievement Award. We chose this particular presentation because we thought that it's a wonderful model of how you can use other members of the care team to provide needed services to your patients. Even though they're coming to the clinician, there are other people who can make a big difference. So let's turn to Dr. Hamilton. Thank you.
So do you have slides that I sent you?
Yes, we're going to pull up your slides.
Great. And is there a way that I advance them, or do I just say next slide?
Next slide.
Okay. Next slide. So this is a program that actually started in 2013, but the ACL gave us a grant that made a big difference 4 years ago. So currently, it's a no-fee program supported by Hospice of the Valley's board. Census right now is actually up to 800. We're growing. To support people living with mild cognitive impairment or any level of dementia. And they don't have to have a diagnosis, which helps a lot because people don't always get a diagnosis. Either living alone, which is also important because most programs you require a caregiver, or with caregivers. The program is essentially a visit every month for 5 visits, limited due to finances, from what we call a dementia educator, you call it a navigator, whatever they're called. They're a social worker or similar. Caseload is 55. The first visit is virtual, phone, or Zoom, or at home. And the second visit is always at home for reasons I'll explain later. And the last 3 are often virtual unless they live alone. And then all the visits are in person. On the first visit, we do the neuropsychiatric inventory, which lists behaviors, aggression, screaming, whatever difficult, challenging behaviors events. We do the Zaret burden inventory for caregiver stress. We do a mini mental status and sometimes a MOCA and other assessments and develop a care plan. The second visit, which we do in person, is really important because we really stress advanced directives. Both the medical power of attorney and CPR and preferences for hospitalization, which is a huge issue. We ask for people, especially with moderate to advanced dementia, would he or she want to be hospitalized, want their life prolonged by medical means? And we specifically say, what if they fractured a hip? What would you want? Would you want surgery or would they want comfort? And of course, all visits provide local resources, education on approach, and support for the caregivers. Next slide, please. There's an administrative team to answer the phone weekdays, and we're very lucky because as a hospice, we have a live nurse triage team that answers the phone nights and weekends. We've trained them. They defuse crises. It could be, it often is a wife shut in her bathroom with the door locked, with the husband banging on the door. So they're very, very good at helping families. And of course, call 911 if you need to. The medical director, myself, and our nurse practitioner review meds, make suggestions to the family, and also call the primary care doc, who you would think would be upset by somebody else calling, but they're like, I don't know how to manage this. That's great. Thank you. So that has turned out to be very good. Even neurologists who say, I don't know how to manage medications in dementia. If they live alone, we do have a nurse or a nurse practitioner who go out and try out different medical alarm systems to help them do their medications and try to simplify the meds as little as possible. We have an occupational therapist who can do phone, Zoom, or in-person consults. And on the last visit, the 5th visit, we repeat the NPI and the ZBI. We keep them on if they need it. We keep them on almost always if they live alone. Next slide, please. We've cared for over 4,000 patients in the last 3 years, 3,800 with caregivers, 480 live alone, 50 with IDD and dementia. A large percentage, 22%, are discharged to hospice, even though the average mini-mental status is 16 or moderate. And that, I think, is due to comorbidities and the family's decisions not to hospitalize. We found a highly statistically significant reduction in aggression, agitation, calling out, wandering, insomnia, measured by the NPI, and a highly statistically significant reduction in stress to the caregiver. We also had, we're very happy to report, a 48% reduction in hospitalizations during the 6 months they're on the program, and with 28% reduction in the 6 months after. So the effects lasted. Next slide, please. Just one example, and I didn't pick an easy example. I fell in love with his family, Michael and Janet. He was 70 years old. He lived with his wife. They'd been married 49 years. Their disabled daughter had died at age 8. They had no other family. He was independent in his activities of daily living and continent, but his mini-mental status was 8. He was hospitalized first because he was hallucinating and waving a gun around. The wife was very unskilled in her approach. She was used to telling him what to do. We tried really hard to get her to change her approach. The ADPI grant also gave us 4 hours a week of a caregiver to go in and reduce her stress. She was so appreciative. Then he took the car keys. The wife called triage again. Again, we advised her on approach, helped her with placement. Then he was found roaming the community in his underwear and was hospitalized. And at that point, he was diagnosed with pneumonia and sepsis, of course, became very delirious, declined, and ended up dying about 10 days later. Wife was very appreciative, thank goodness. Next slide, please. We published the results of this in Journal of Palliative Medicine. Next slide, please. We did look at diversity. African Americans are 5% of our county population, but only 3% of people over 60, and we enrolled 4%, so we did well enough. Most interesting, they began the program with statistically significant, more severe symptoms and more caregiver stress. And then they had a higher reduction in symptoms than whites, and they ended the program with lower stress than whites. We were very happy about this and surprised. And so we hired an African-American outreach coordinator part-time, and she started talking to families. And what they said was, we've never had somebody come into our home and explain things to us and give us all the time we needed. They were generally suspicious of the medical system, understandably, and felt that when they went into offices, they were not given time or respect. So even though we didn't have any African-American coordinators to go in, that didn't matter. It was that they gave them time and met with the whole family because they were reluctant to ask for help, which is why their stress level and behaviors were worse in the beginning. Next slide, please. Oh, next slide, just if somebody wanted the data. And again, next slide is just the data. We did the same with Hispanics. Did we enroll a representative population? Hispanics are 30% of our Maricopa County population, but only 11% of adults over 60. It's a very young population. And we enrolled 13% Hispanics. We just hired an Hispanic coordinator, so hope to go up on that. And same but smaller differences compared with non-Hispanics. Hispanics showed greater improvement in behaviors and slightly greater reduction in caregiver stress than non-Hispanics during the program. And they said the same thing, that often when they went into the doctor's office, only 1 or 2 people were allowed in, and we have 3 bilingual, bicultural navigators, so they were able to meet with these families, and they would meet with 13, 14, 15 people at once in the home. So they really, really appreciated that, and they could go back and forth in languages, because usually the older person might speak only Spanish, but the children would speak English. Next slide, please. Next slide. Just included these in case anybody wanted them. Next slide. Living alone with dementia. This is my favorite area because it was our most challenging. In the research, it shows that about 26% of people living with dementia live alone. In our cohort, and we examined about 350 people, one thing, most were female. And yet with dementia, most of the people living with dementia were pretty equal male and female, but living alone, it was the females who were out there. The mean mini mental status was 21 out of 30, so a mild dementia, but the range was great from advanced to very minimal. This is interesting. The same ethnic distribution as those living with caregivers for whites and African Americans, but for Hispanics, 13% of our population lived with caregivers, but only 6% lived alone. So Hispanics kept their family member with them much more than other groups. So we had the same results as those living with caregivers, less behaviors, increased support, less hospitalizations, although much smaller amount. And for those living alone, this is the thing I found most interesting. The distant caregivers, they might live in another part of the state or in another state or in another country. Their stress level was just as great as the stress of the live-in caregivers. And the program reduced their stress equally. But I thought that was really interesting. I would have thought if they didn't live with them, it wouldn't be as stressful, but it was. And maybe as a parent with grown children, I see that when my children are distressed, I'm very distressed. So maybe it's like that. Next slide, please. So many examples of people who live alone. This was one we became very attached to, 87-year-old Asian male, referred by the local senior center. We saw him a year ago, and he was independent in activities of daily living. He was continent. His mini mental status was 16 out of 30, so a moderate level of dementia. He had rotten food. He had pills dated 1984. He had no hot water, which he didn't seem to mind. He kept his thermostat off because he said he couldn't afford the air conditioner, even though I found a $99,000 bank statement on his table when I visited in July. He told us he would rather die than move into an assisted living. And his brother confirmed that. He said even coming to visit his brother, he was distressed. He'd always been alone, never had a partner, and his brother supported that wish. Of course, everybody worried. Then he was hospitalized with hematuria, blood in his urine in August of this year, became delirious, had to be restrained. His brother insisted on taking him back home, saying that it would be like prison or death if he put him in a facility. He had plenty of funds. And the brother signed an advance directive for no hospital, even if a hip fracture, just comfort. He did have home care people 4 days a week, but 8 days later, he went back to the hospital with dehydration and died after a hospitalization. And the brother was actually very appreciative. I had another call just last night from a woman we've been following for 2 years who lives alone, not quite dementia advanced enough. She has sort of mild to moderate dementia, mini-mal status of 19 when I visited in September. And this was the neighbors called the daughter because she was running around outside barefoot, banging on their doors, and carried out a garbage can that was on fire. So we immediately sprung into getting her emergency guardianship. But these are families where you sometimes just have to wait and then step in when you can. Next slide, please. For a hospice, and many hospices have called us about this when we've made presentations, it's an incredible service. Physicians love the program. They provided more than half of our 4,000 referrals because, as I think I heard at the previous presentation, physicians don't have time to do any of this and they don't know what to do. So our average level of dementia for the program was 16, which is a moderate level. And 22% of our patients were discharged to hospice, usually after only several months on the program. And that was because of our careful discussions with families about goals of care, which is easier with dementia than other diseases, because people with dementia do terribly in the hospital, as I'm sure you know. Almost all of them become delirious and often have to be restrained, and it's a nightmare for the patient and the family. And often the families would say to us, "You mean I don't have to send her to the hospital? I thought I did." I said, "No, you don't, not if that fits what your family member's goals would be." And they say, "Oh my gosh, he would never want to be alive like this." So that's part of the reason why they often go on to hospice. And I'd love to hear your opinion of that. Next slide, please. One slide on GUIDE. I think you all know what it is. It's CMS supported. It is essentially our program, which is wonderful. It just started in July. We have about 40 people on the program now. It requires that the person be fee-for-service only. And in Arizona, about 60 to 70% of patients have Advantage plans. So about 30% of our people are eligible. It reimburses about $275 a month for the first 6 months, $150 after that. Same components that we have: a navigator, clinician review, 24/7 helpline. The nice thing is it provides $2,500 a year per patient for respite, either in-home respite, in a facility respite, or adult daycare. So that's a huge benefit. It's not a lot of money, but it's something. And it will continue for 8 years. And the data will be tracked for payments, costs, and caregiver stress. Next slide, please. I think that's it. Okay. Any questions are most welcome.
Yeah, thank you, Dr. Hamilton. We chose this because you developed an ideal model that is now very much like GUIDE. People would wonder, well, why did you develop this program so long ago? Where did you get the idea to do this? Can you start with that perspective? It's so innovative.
We started in 2013 because we had an outreach program for all diseases. heart disease, lung disease, stroke, whatever people had. And people with dementia just didn't fit. So they would say, well, they can't go on the program because we don't know whether they're going to die in 2 years, or we can't just take care of people with dementia. And I said, heck with this. We're going to start a program just for dementia. But it was the Administration for Community Living grant 4 years ago that really had us take off. We modeled it on care ecosystems, which is a model that's wonderful. They don't do in-home visits as part of that program, but we just included that. So they were very helpful. And of course, ACL was incredible. And that's how it happened.
Thank you. I see Helen has a question on the phone.
Hi there, Dr. Hamilton. My goodness. Having been part of the original advisory council on the care ecosystem, I applaud you for expanding on it. You know, and so, but the referral process. Now, I saw on one of your slides that it could come from the senior center. It could come from, how do you get out there in the public know, so to speak? And then how did I mean, I've got actually a couple. So that one I think is probably the biggest one to unpack. So what about age limitations? Can you address very young onsets, all the rest, or does your funding limit you more so to people 65 and above? And how do you get past the bias of people thinking the term hospice is kind of scary to them, so to speak? I'm dying, get past that.
Three great questions. As far as referrals, it's a mixed blessing. We're a program of Hospice of the Valley, which is way the largest hospice in our area. It's nonprofit, the only nonprofit left standing. We have about 48% of the market share. We have 250 hospices in Maricopa County. It's incredible. So we have name recognition, which is a blessing in that everybody trusts Hospice of the Valley, but as you say, it's also a downside because hospice, no, we don't want anything to do with that. So, however, one blessing is that we have community liaisons who go out to physicians' offices, organizations, churches, and they let people know about supportive care for dementia in addition to hospice. So that's a lot of our referral base. We're very well known. Getting rid of the hospice thing, we don't have Hospice of the Valley. It's such a mixed blessing because, as you say, we don't want to put hospice on our cards or on our materials, and yet they're how we get recognition as a trusted organization. So we try to walk that line carefully. As far as age, it doesn't matter to us, and as the rest of the country, we're getting younger and younger people. We don't worry about age at all. And we have a program, again, thanks to Aaron and the ACL, which we would not have done otherwise, which works with people with developmental disabilities and dementia. So some of those are quite young. So we work with that population also.
Thank you so much. Great.
I see Ken has a hand up.
Yes. So how would other states implement the hospice service for dementia? Because, for example, when caregivers hear, dementia caregivers hear hospice, they don't understand. As you said, it may take 2 years, 10 years, 6 months for someone with dementia, may pass. So it doesn't even enter into their brain until something really critical happens. So if this were to be implemented in other states successfully, from financially for long term, how would a hospice implement this? How would they make it work?
Well, more and more hospices are starting palliative care programs as a runway. It's an incredibly competitive business. And unfortunately, it's a business, hospice. So they are starting to create these runways palliative care programs early on so that those same patients will go to their hospice. In fact, we do lose people that we've taken care of for a year or two to a different hospice because they don't have to choose ours. But I think we get a lot of calls from hospices saying, how do we set up a program like this? Most of them don't have a board like ours that really believes in providing service to the community. So they're usually nurse practitioner based so they can bill for their services. We don't bill for anything on this program. Did that answer your question? As far as people with dementia getting on hospice, that's a tough one.
Right.
And I actually go to battle with our own admission department every week over somebody who looks like they are terminal, but they don't fit the FAST or they
Right,
don't
right.
fit, the local guidelines, because dementia is so different. And
Yep.
each type of dementia is different. Now, if they have frontotemporal dementia, they're going to be walking around just fine, but they're going to have major other issues.
So it needs a miracle in other states like what you did in your state.
Thank you,
This is
Ken.
really doable, though. And oh my gosh, the good we do. It's just so wonderful to see how helpful it is. My latest foray is legal because we have in Arizona, we have a program called Arizona Long-Term Care System, or ALTEX, which is Medicaid for people at a nursing home level of care. Every state has it. And to qualify, you have to have a lot of physical debility. And people with dementia may be walking around and not have this stability, so they don't qualify. So I just wrote a grant to get more help to approach Altex and have them understand dementia better. And the other
So-
area where we're battling is guardianship because it's so expensive.
I'm going to go into another question. I see Rhonda, then we'll do Bruce, then we'll do Roberta, and then Joanne.
Thank you so much, Dr. Hamilton. So serving in a public health department and Ken's great question about how to take this really, I think, wonderful work and apply it in another state is central to my mind. But I wanted to ask you, what would you like to see over the next 2 to 3 years? What's your vision for growing this body of work that you might want us to know as we take what you've learned and apply it elsewhere? Thanks.
Well, I think GUIDE is a great model, and we are now trying to market this to local insurance companies because it all comes down to money. Everything in the world comes down to money. No, that's not true. So we have gone to Cigna and Humana and our local companies to show them our data, because the insurance companies are willing to pay for something that will lower costs. And primarily that's lowering hospitalizations because they don't pay once they go into memory care. The insurance company doesn't pay, somebody else pays. But if we can show them that we cut hospitalizations by 50%, I think insurance companies will buy this. And that's what's so great about GUIDE, not just that it's doing it, but that it will demonstrate to private insurance companies. Did I
Thank you. We'll
answer
go to
that?
Bruce.
Yeah.
I think you I was going to drill down more on the sustainability piece of this. And I think this last question kind of got to some of that. So I'll let you keep going.
Thank
That's
you.
our
You-
sustainability plan.
So you have GUIDE, which is going to be your fee for service. Then you're saying you're going to Medicare Advantage through the insurers. So I think that's really helpful. So let's go to Roberta.
Great. Thank you, Dr. Gillian. As a former caregiver, just really appreciate hearing hearing that this exists, right? I'm in California, and it's not so much a question, but a reflection as I'm hearing you speak to the work that you've been doing and then reflecting on what we've heard in the past two shares, presenters, that this idea of community, right? And how do you provide a space where there's multiple people just involved, right? And I think you had asked us when you were covering the part about hospice and how specifically families, the whole the fear around hospice, right, and the hesitation around that, and I guess I just wanted to share or bring up that for us as our family, it wasn't something that we really considered until the impact and the reality of, like, if something were to happen to myself as the primary or my spouse who was like my partner, like, how are we going to do this? And that kind of shifted it to realize, like, we needed a team. And I almost wonder, like, as you continue to do the work, or as folks try to replicate this, sustain it, it's almost like the messaging around what hospice is in the context of dementia or of any other cognitive need is that, where's your team? And where is your, right? If it's not existing with your family or chosen family, like, folks need to consider, well, who do I have a team with me? So I appreciate that that's just ingrained in what you are doing. So that's all. Just wanted to share that.
Thank you.
Thank you, Roberta. Joanne?
Yeah, thank you, Dr. Hamilton, for sharing so much about your experience with Hospice of the Valley, and in particular, some of the parts that you describe as being excited about with GUIDE. We at the Alzheimer's Association are too. I think one of the things that we consistently hear from our partners within GUIDE and in other providers is the respite that we know is so important, while funded within this, is not enough. Can you speak to your experience on the respite amount and what you are seeing so far within the delivery of that side?
Yes. The respite amount, it's not just $2,500 in GUIDE. It's a certain amount. For instance, for home care, it's $30 an hour average. And in Arizona, it's $29.80 or something. Whereas the going rate in Arizona is $35 to $40 an hour. So we're hearing from all over the country, people saying, where are we going to get a company to do this? We have contracted with 2 companies and they whine and scream, but they want to be part of this because they see it as the future. So they have agreed to do it. The same thing with adult daycare. Our own we have a campus which has adult daycare and assisted living and so forth, but and we charge much more than the $80 a day that they're offering. But we're going to do it because we all want to be part of this experiment, which is a big step forward to be able to show it. So that's the general, and we've heard from other parts of the country they can't find anybody. So far we're okay. We just have to listen to complaints.
Can I have one more thing? And so it's great to hear that you're talking to, well, about the program, of course, but you're talking to insurance plans. And I just want to, again, reiterate that if there are any MA plans out there that are taking advantage of the research and the programs and the infrastructure that has been created, the outcomes in terms of both the patients and the caregivers, and then, of course, cost savings, which might be what an MA plan is worried about, we would welcome them to come. So if you have any luck, please share that. We would love to hear why they chose to do this, what, the business argument was to provide it, because GUIDE is a demonstration program and it will go on for a number of years to demonstrate that it works. But an MA model that picked up a guide-like program like what you've been providing could be providing this right away. And we would love to give them the platform to share that information at one of our meetings.
So you're from,
Oh, sorry, this is Helen Lamont from HHS.
oh, okay.
From
yeah.
this advisory council. We'd love to have them at one of these advisory council meetings and the platform that we have here.
I think we're going to be successful because we already contract with them for heart disease, cancer, and lung disease. However, they only cover 2 or 3 months, usually after somebody's gotten out of the hospital before they go back in. We're going to try to insist on 6 months, but we're much cheaper. Our whole program costs $250 per patient per month because it's social workers and just me on the phone. So I think we will be successful. And when we are, I will let you know. I'll let Erin know. She knows all.
Thank you.
You know, you've highlighted the fact that you've developed this program for a needed group, and you happen to be in GUIDE, and you're trying to figure out how to do this for Medicare Advantage. But GUIDE is not nationwide. And so being able to replicate it in places that will not be GUIDE selected, it's helpful to try to think about how can we take these learnings and use some of the new other Medicare codes. There's a new code called Principal Illness Navigation that can be used in fee-for-service, where a person can be at risk for nursing home, functional decline, or death. And that is a code that can be used once every month. I mentioned the community health integration services. As we begin to see how the components that you're doing can potentially be billed under fee-for-service with these new codes, I think that'll allow us to extend some of the learnings from GUIDE, even though they're not going to be GUIDE selected. So I really appreciate you really giving us a true description of what your program is like, and the fact that you did this without initial funding. Because it can be replicated. This is live streamed, and so people all over the country is hearing about how this can be done. I very much appreciate that. But some of the parts initially you started without any funding. So thank you for giving us that presentation. We're about to now break for our lunch, and we'll be back for those on the line. We'll be back at 12:45. Thank you.
Produced by the U.S. Department of Health and Human Services.